The terrible decision of suicide, coming next on Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. We start our show tonight with a question about suicide and suicide prevention. Those of you who call in or email us with the correct answer will be in a drawing to receive a copy of our book, A Picture of Health. This week's Prairie Doc quiz question touches on two subjects that have emotional responses, but they must be part of any serious discussion of suicide in today's world. Tonight's question is, the risk of suicide for teenagers is 4 to 10 times higher if they live in a home where guns are present than in homes without. True or false? Call in your answer. And by the way, we answer your questions as they're called in and sent to us via Facebook or email. We want your questions. That makes this show. This is a very important show tonight. Please give us your calls. Joining us tonight to visit the very serious topic of suicide and suicide prevention are Shawn VanGerpen, MD, and Matt Stanley, DO. Both are with the Avera Medical Group, University Psychiatry Associates of Sioux Falls. So let's start with a question for both of you. How often in your practices do you find yourself dealing with a patient who is in significant danger of suicide? Weekly, monthly, daily? And you know what? I'm going to have you percolate on that idea, and I want to find a little bit more about you first. So, Shawn, you're from where?
Originally from Tyndall, South Dakota.
So you're a Tyndall boy.
Tyndall boy.
A Tyndall, I know Dave Meyer, the orthodontist, was a trackster from Tyndall. Did you run, or were you in the track team?
Did a little bit of everything, football, basketball, track.
Football, that's right. And did you play football in college?
I didn't. I decided that if I wasn't going to pass enough classes to get to medical school, I probably couldn't handle doing both.
Yeah. So, and you went to USD or SDSU? Or?
USD for undergrad, and then medical school, and I'm still a member of the faculty of the USD.
Yeah,
so.
Half your time is spent teaching or resident teaching.
Yeah, I'm the adult psychiatry residency director, and then my other half of my job is as a child and adolescent psychiatrist.
So you're a child psychiatrist?
Yep.
Great. Well, nice to have you here.
Thank you.
And Matt, you're an old guest. You keep coming back. I don't know what it is, just like a penny?
Penny? Yeah, okay.
You're from where originally?
Shenandoah, Iowa.
So, and you went to where undergrad?
South Dakota State.
Oh, SDSU in Brookings.
Right. That's right.
And on a football scholarship, I think.
Right.
So you played football there for 5 years.
Yeah, which is probably a little too long, right? I was in the slow matriculation program.
Yes, yeah. No, that's that extra year, the red shirt and all that stuff. So, and what brought a football player from SDSU to decide to go into psychiatry?
That's a great question. So I absolutely loved my psychology courses here. However, when I went to medical school, I intended to be primary care or pediatrics. But in your medical school rotations is where you really kind of find out what you're drawn to, as you know, and Shawn knows. And I just found, I'll tell you what tripped the trigger for me was I did a rotation in a 24/7 psychiatric emergency room in downtown Kansas City, and just saw the most amazing stuff. Just fascinating. Every story is different. So that was what really turned me to psychiatry.
Well, I mean, it's such a, like you say, every story is so different. As a primary care doctor, an internist, I would say fully 50% of what I see has a significant psychiatric or a psychological component to it, because particularly if you have an illness that causes a pain or you're feeling debility, those things have a psychiatric ramification.
So you know what's making that more evident, sorry to digress a little bit, but with the Affordable Care Act, where we're kind of grouping patients' recovery under one doctor, monitoring it in one single path.
Yeah.
Identifying that there's a major psychiatric illness as a component of most of these chronic illnesses has elevated the discussion of treating mental illness remarkably.
Which is a good thing. And there have been some changes as far as payment for mental illness recently too as well.
Yeah, I would say in general the trend is positive for us in terms of behavioral health.
So the question I asked you earlier was how often in your practice do you find yourself dealing with a patient who has significant risk of suicide? Shawn, you're the pediatrician, psychiatrist.
With the way my job is and my job description, I maybe don't do as much outpatient clinic, and I don't do much at all for inpatient. So I have a little different practice, so I probably don't get as exposed maybe as often as some of my partners do. But I would say that probably once a week, maybe not necessarily a real severe acute case, but having to deal with someone that says they've been having some suicidal thoughts, maybe they kind of come and go, maybe it's not real severe yet, but how do we kind of work to prevent it from getting to be a bigger issue? I think a lot of kids, especially depending on situations that they're going through in their life, it's more of an impulsive thing sometimes, so a breakup with a boyfriend or a girlfriend or just something like that can trigger an adolescent to have some of those suicidal thoughts.
That whole impulse thing we should talk about, because kids are a little bit more, well, significantly more impulsive in their actions than adults. How about you, Matt?
Well, like Shawn, my duties have changed a little bit over time, but I spent most of my time as an acute inpatient psychiatrist, so it was definitely daily, and probably 40 or 50% of the people that I was seeing every day either had suicidal thoughts or were actively suicidal. So, but that's again, like Shawn said, that's a slice of practice that's different. That was an inpatient acute psychiatric, and a lot of those were involuntary committals as well.
Right, and that's one way we can get a person into the psychiatric hospital when they have attempted suicide. That's the open door to get them in. That means that they need help. Do you think that people get to the psychiatry service or get into the hospital every time that they need to? I mean, sometimes it's hard for us to get them in. When I suspect that there's a problem, they don't get in. I can't get them in. Or if I commit them to Yankton, they'll get down there, they'll play the catch-22, whatever it is, and then they're home.
Yeah, so that's a complex question with a complex answer. So the access to psychiatry, just based on numbers, as we talked about earlier, primary care probably sees the vast majority of behavioral health issues. But you mentioned, if you have a high suspicion, or certainly if someone has attempted or is threatening to attempt, there are the committal laws in every state, essentially. So that at least gets someone into a safe environment where they can be evaluated. But I would say that the more complex question, the harder question is those who have suicidal thoughts or are severely depressed, but won't seek help or won't allow help to be given to them. And some of that is not necessarily all stubbornness or refusal to seek treatment. The thing that you have to remember, and I hear this repeatedly from people who've had a loved one suicide, they will say things like, "He would have never done that," or "That's just not like them." But depression, when it is severe enough, will change your perspective and change your way of thinking. Think of it in this way. Severe depression can make you hear voices or even see things that aren't there. It can certainly change your judgment and can induce in you severe feelings of guilt or inadequacy or failure, to the point where you think people are actually better off if you're not here.
Right, the sense that I'm going to relieve them of all of the burden of my presence. Do you sense that depression is always the cause of suicide, Shawn?
I think if you look statistically, about 90% of people that commit suicide, adolescents, have either a mental health diagnosis or a substance abuse diagnosis. That being said, going back to the impulsiveness kind of question, I think there's a lot of things that happen, especially with kids and teenagers, that just for no reason, all of a sudden the thought pops in their head that no one cares about me, no one loves me, they'd be better off if I wasn't here, and you get these real impulsive acts. And so I don't think it's all related to depression. I think a lot of it is related to mood issues or to substance abuse being another one is a huge contributor to that. But I think there are those cases where it's very situational, but unfortunately for kids, they don't see past today.
Right.
It's hard for them to see 20 years in the future what life might be like. They live in the here and now, and some of the things that those kids go through, just really in their mind, that's the end. There's nothing that they can recover from, and unfortunately they don't see that there is a tomorrow.
There is a tomorrow. 6 years ago, Kate lost her 14-year-old brother to suicide, and it changed her forever.
To be honest, our family really didn't recognize what was going on with him. We didn't understand. I knew that he did have depression, that he was diagnosed with it, and that he was taking medication for it. I did not know the severity, because my brother, like, for the most part, he was like a happy 14-year-old kid, beautiful soul. Obviously, I miss him a lot. Losing someone by suicide is a lot different than losing someone any other way. Any loss is hard, of course. Suicide has the added complication that you have to come to terms with that person did this to themselves, that they were in that dark of a place. We do have a very strong faith life as a family, and I'd say if anything changed, that got a lot stronger, because that was what we fell back to try and, you know, heal from that loss. I know for my family, like, we're still healing. We're definitely not, I don't think it's something that you're ever fully recovered from. Like, you're never going to be like you were before this happened. But yeah, it's a healing process, and I think it's going to take our whole lifetimes to, you know, come to terms with this loss. Yeah, I think, like, the best way I could explain what it's like is, like, you know, you feel like you got hit by a semi-truck, but you didn't even realize you were walking by the highway, or like, you didn't even realize there was a road. So it just comes right out of nowhere and, like, just changes everything. There were a lot of things that people said that hurt much more than they helped. And the thing that helped the most was when people were just there. You don't have to say anything. You really don't. Just say how sorry you are, that it's such a loss, that, you know, it's honestly a huge tragedy. It shouldn't have happened. Like, people that are lost that way, that's a tragedy, and it can never be anything less than that. It'll just come up in conversation like, oh, you have 2 brothers. Yeah, I do, but my younger brother died. Oh, how did he die? And then I have to tell them, like, he died by suicide, and they just get this look, and they do not know my brother based on how he died. His life is so much more than how he died. So I would definitely recommend, like, don't make conclusions about that person based on how they died, because you don't know where they were at, you don't know what was going on in their lives. It's much more than what you're presented with. So don't make judgments. I mean, there is such a stigma, you know, with suicide and depression and everything. And there can't be if people are going to talk about it and get the help they need.
Well, Kate's in med school, and you could tell how hard that was. But what kind of guts a person has to have to be able to give that interview? So thank you so much for that, Kate. What's your response to what she said?
I think the thing that kind of caught me the most with what she was talking about was just how families, when you lose someone through suicide, it's just the uncertainty of why did this happen. You know, I think one of the things that when we have issues with cardiac issues, when someone dies by way of an MI or it's cancer, we have some explanations as to why this occurred. It's not like that necessarily with suicide. A lot of times I read somewhere an author had put in a book that when you die by suicide, you take your secrets with you. And essentially, we don't a lot of times know the answer as to why someone decided to take that as a way out. But it also gives us hope that, you know, through what we can learn from people that have gone through this before, that we can take that to help prevent these for others.
That prevention is the issue. Matt, you had?
Yeah, so as you said, very courageous by Kate to talk about it that way. Several things she said really resonated with me. And just like she said, getting hit by a truck, never seeing it coming, never believing it could be someone. And that's what's so difficult. It leaves such a legacy of pain and guilt and confusion. And it isn't something, and I think she said it well, you know, it's something that will always be with her. And it is one of the protective factors we try to tap into sometimes when people are suicidal, to you know, try to reconnect them with how their family will be affected, and not necessarily to develop a sense of guilt, but just to try to reconnect how important they are to those who care about them and the impact it'll have.
Oh, yeah.
I think the faith part that she talked about too is very important. I mean, a lot of families, I think, rely on that, their faith to get through these episodes, and it seems like in her case that's something she's really fallen back on to help her get through this.
She made a comment about people saying hurtful things, and I think they didn't mean to. I think they were trying to say something to give her support, and people don't know what to say. I think that goes with any death. And I have to say, you know, the talk about the repercussions of a death from suicide, there's a repercussion from a death no matter what happened. My sister was killed in a car accident. It will I'll never change. I mean, I was never the same after that. And I realized what you can say when there's a death in somebody's family and give them support. Don't need to say a thing. Just be there. Just be there. So we've got questions. 70-year-old woman from Madison comments, attempted suicide 15 years, and what pushed her over the edge was that she thought that no one cared for her. What's your comment about that?
I think that's a sad reality for a lot of people that contemplate taking their life. And the fact is, I think we get a lot of times so depressed that we don't see the bigger picture. We're not able to see that people do care, that people do love us. And I think even as family members, sometimes we struggle to show that to people when they seem depressed because we don't want to hurt their feelings, we don't want to make things worse. I think the biggest thing we can do as family of someone or friends of someone we think is hurting is tell them we love them, tell them we care about them, tell them we're here for them, we're supportive of them. But a lot of times our patients and people that are going through this don't hear that.
Right, that's it.
Yeah, and I would say again, back to that, you know, the way that depression can shift your thinking, change your perspective, and give you thoughts that aren't necessarily based in reality. But you have to understand, as someone who's not experiencing it, to that person it's exceedingly real. And as Shawn said, I think one of the best things we can do is be active listeners, let them know we're engaged and care. But that's hard, just like Kate said, you know, the hardest thing about it was that he did this to himself. And to try to understand where people are at, that's part of the education when we do work post-vention with people that have experienced a suicide, is to try to understand the pathology. Because I think if you haven't suffered that severity of depression, you just can't conceive of the impact it can have and how much it skews your thinking.
So let's talk a little bit about the treatment of depression, because that's really a lot of the treatment for suicide, isn't it? How successful are we? I mean, people get to a level of depression that can be overwhelming. How successful are we at being able to treat depression, you know, in a way that people are out of it, come out of it?
Well, I would say, so depression is a lot like other illnesses. There are gradations of severity. So yes, you see people with fragile diabetes. Very hard to keep them maintained in a nice laboratory level of blood sugar. The same thing with depression. So you see some folks that will respond relatively quickly or successfully to medication and counseling, and you see others who struggle throughout their entire life of episodes. So there isn't a single great answer to that. Antidepressants typically in studies show about a 40% success rate in the first try, and each successive try will typically go down a little bit in percentage points. There are interventions like electroconvulsive therapy, ECT, that has closer to the 70 or 80% success rate in treating depression.
So ECT really should be something we should consider more often.
Well, it's a heavy gun. You know, it involves anesthesia. You know, it has a lot of impacts on the body. I do ECT. I'm a big believer in it, but it has to be used selectively, much like bariatric surgery for people who are overweight. You can't turn to it first necessarily, but it has its place in your armamentarium. But it is one of the quickest ways to get people, particularly with suicidal thoughts, to try to change that severity of that illness and that distorted thinking pattern.
So that flies totally in the face of one flew over the cuckoo's nest story, which has just, you know, negative.
It's been the greatest disservice to ECT of anything I can ever imagine. So I have every nursing student, every medical student, everybody I can get come in and actually watch a course of ECT, because it is entirely different. You know, we anesthetize the individual, they're hooked up to all kind of monitors, we relax the body with acetylcholine. So there's very little, if any, movement actually during the treatment itself.
Okay. And they don't lose anything. What they do is they gain a chance of escape from the severe depression. But you didn't say exercise. I always like to talk about exercise as a help in depression. What's your take on exercise?
I know there's been studies that have come out that have shown that exercise can have equivalent benefits to antidepressants, and depending on the studies you look at. So I mean, I think when you look at the benefits of exercise, it helps reduce stress, it helps get the body's natural chemicals and endorphins fired up, which are natural healers. I think diet actually plays a big role in that as well. I think a lot of times we rely on or think medications are the whole answer or therapy is the whole answer, but it's really treating the whole body. And if you can get that exercise going, that diet going, I think a lot of that. Sleep is another big one. I mean, we want to make sure we have good sleep patterns. If we don't, that definitely can delay a progression or improvement in depression. So those are all very important things.
So I want to be cautious so we don't contribute to the misperception of mental illness, because I agree with what Shawn has said, but I would go back to the diabetic analogy. So you take a severe diabetic, you can control their diet, you can put them on good exercise. That will not get their blood sugars within control. It is a component. You will require insulin. You will require, for those severe. Now, someone who's in that borderline range, where it's developing, totally agree. You would certainly want to start with less invasive treatments. But one of the things we struggle about in mental health treatment is people feel guilty. They feel like with more strength of will, with more effort, with more discipline, I shouldn't feel this way.
Yeah, I can pull myself up.
Absolutely not correct. Absolutely not correct. I think that we all can do better, and we make it a component of our treatment. We talk about exactly what Dr. VanGerpen talked about: exercise, sleep, diet. Those are all important components. But when you reach a level of that pathology, you need active treatment.
Okay. 46-year-old man from Minnesota says, I have an alcohol problem and depression. If I seek help, I'm afraid I'll be told to stop drinking, and I don't think I can do it. Who should I talk with? My primary care doc doesn't know the extent of my drinking.
Well, my first response would be, your primary care doc is well-trained, will understand what you're talking about, and I would come clean with him. But if he's not comfortable, if this individual is uncomfortable with that, we really can't treat depression, to step back, in the face of active substance abuse. It's almost impossible. The drugs that you are injecting into your body are at least as strong, if not stronger, than what we are trying to do to rebalance. So for that individual, getting the chemical dependency under control is going to be as important as anything else you're going to do. But there are a lot of programs and individuals dedicated to that. And for almost everything in healthcare, your primary care doc is probably the best doorway. I know that there are
the starting point.
Yeah, I know there's numbers you can call. There's facilities that specialize in chemical dependency. That would be another approach. But
so I mean, really, if you would look at the numbers of suicides in this United States every day, how many of those die with alcohol or substance on board and or had substance abuse as part of it, Shawn?
I would say a significant majority of those, going back to that 90% statistic of 90% have either a mental illness or a substance abuse issue. And when you look at that, there's so much comorbidity between depression and anxiety and substance use and all those things that just kind of affect each other and work together to kind of end up being overall the component that really makes people struggle, because I'm trying to deal with my depression, but my anxiety is getting worse, or my substance abuse is making my depression worse. It's kind of this chase your tail kind of thing, and people really struggle to be able to get a hold of that.
This manic depression or bipolar disease is different than just pure depression. It's an up and a down and an up and a down. Do people more at risk with manic depression than just depression?
Yeah, the rates are just a little higher. In part, sometimes because you do things when you're manic that then when you're depressed, you have such great remorse and regret and embarrassment about that can be a driving force. So the statistics are similar, but that's definitely a relatively high risk factor.
All right. A 75-year-old woman from Huron, can anxiety be a contributing factor to depression? What about anxiety and depression, or are they together, or are they related? What about anxiety and depression?
You look at kind of the chemical makeup of anxiety and depression. I mean, we're looking at the same kind of chemical imbalances. I think serotonin, norepinephrine are probably the two biggest chemicals that play into this. So it's very common to see someone that struggles with depression also have significant anxiety issues, or vice versa. And if you think about it, as your depression's worsening, you're probably getting more anxious because of how you're feeling with your mood, and vice versa as well, that the mood is going to get worse as the anxiety gets worse. So they definitely do go hand in hand, which if there's one benefit, the one nice thing is some of the medicines we use to treat depression also treat anxiety, so we can kind of get help for both.
Right. I have turned away from the old anti-anxiety drugs, the benzodiazepines, which seem to, in the long run, make the depression worse, and pretty much use the SSRIs, which treats depression, and when you see that happen, their anxiety is reduced. I mean, it's a powerful anti-anxiety drug.
Yeah, and as Dr. VanGerpen said, we're fortunate that, so we term those drugs as antidepressants. It's a little bit of a misnomer because they're also very good at anxiety.
Yeah, another way of looking at that is people talk about, well, they were depressed, but in guys, I don't think they get so much depressed as they get angry. Or in guys, they're a different animal, and that illness in the brain presents in a different way than it does in a woman.
Well, and a lot of people don't recognize anger as a symptom of anxiety or possibly depression. I mean, they just view that as a difficult person, or,
yeah.
But it's often a symptom.
Especially in kids and adolescents. I mean, a lot of times you don't get the typical depressed presentation, but aggression, irritability, definitely that is how a lot of times it presents.
Well, so let's talk about suicide in men and women. So let's look at the graphic. Suicide among males is 4 times higher than among females. Males represent 79% of all U.S. suicides. So men are at much higher risk than women of suicide. But then the statistic that always gets me is that way more women attempt suicide than men.
Yeah, probably up to 4 times as often. It's the lethality of the means that most men choose.
So when most men choose
firearms. So firearms, it really doesn't leave a lot of room for a mistake or a reconsideration. In women, it's most often overdose or poisoning. So sometimes there's rescue opportunities there.
Right. So any comment about the difference between a man and a woman in general?
You know, I think the causes sometimes of depression, which leads to suicide, can be different. I mean, you're dealing with, in women, a lot of hormonal changes as they're going through pregnancy. Those kind of things can be a major player in all this. But I think the big thing, going back to the firearms, I mean, some studies show over half of all suicides, completed suicides, are done by a firearm or with the use of a firearm. And that really goes back to a lot of training, especially with the kid side of parents, on making sure we have our guns locked up in the home, making sure we have trigger locks on our guns, keeping our ammunition and our guns in separate places, because this really is a significant player in why a lot of adolescents especially lose their life.
I think especially when we talk about the impulsivity of the act. So sometimes, you know, we feel like if we can make someone think between I'm going to commit suicide and it's 6 or 8 hours before I can get the means, that's a long time to potentially reconsider. So it's been said, you know, if someone's committed to killing themselves, it's very, very hard to stop. But I've seen people actually with gunshot wounds to the head that they survived, and their first words out of the mouth are, I'm so glad I'm alive. Even though now, if you thought their problems were bad before, now they have a severe
big hole in their face.
Yeah, they've got all this reconstructive surgery to go through. They're in pain, but oh my God, I'm glad I'm alive. Amazing.
I think the substance abuse, though, is the same kind of thing. How many patients do we see that come into the hospital because of a suicide attempt or thoughts of suicide because they're under the influence of some sort of drug or alcohol, and the next morning when that is wore off, it's something they never would have considered had they been sober or clean.
Right.
Tell someone, tell someone, tell someone. That's the message the Be a Lifesaver organization is trying to teach high school students.
So my 18-year-old son killed himself and died on May 1st of this year. And we were pretty shocked to find out that he'd actually told a number of people what he was planning. And so we actually found out that 80% of those who commit suicide tell someone what they're going to do. And we decided that that needed to change because young people aren't trained on what to do. So we want to empower the youth to tell someone It's not an us and them when it comes to suicide and suicidal ideation. We want to empower them and also give them a way to communicate with administration of the schools if they don't feel comfortable going in personally, to do it anonymously. I'm not mad at the people that he told that didn't tell. They didn't have the training. So we need schools to contact us so that we can train the kids on what to do. There's a presentation so that they can relate to Ian and see that he wasn't any different. He was not the kid wearing black in the corner. He was outgoing and funny and a member of the South Dakota National Guard and a member of the Brookings High School band, and he had lots of friends, and this affected a lot of people. And so, you know, a lot of kids can relate to him. And then of course we want to tell them, tell someone, or tell someone. And then I also want to provide resources, because in this whole thing, the National Guard actually provided me with some of the resources available, like the South Dakota Helpline. I had no idea it existed. I didn't know that. So if I provide all of the resources that are available in each community, then if it comes to be where they need those resources, then they'll at least know where to look, or they'll at least know what's in their community.
Depression and suicide in our society carries such a strong stigma with it, and it's a two-way stigma. You have those that feel depressed or suicidal, that it's such a personal thing that your first instinct isn't to talk about it because it is so personal. And then on the other end of that, people that you feel might be able to help or who could provide resources in the future, it's hard to hear at the same time. And with the stigma, it's not as if we're very well equipped on how to handle that. And so with this organization, our target audience is teenagers, and just to, you know, educate them on resources, but then also to give them the means to tell somebody while still maintaining that personal feeling. By using this, it allows them to get that information across in an anonymous way. So then that stigma that is so often associated with it isn't something that's in the forefront. A person with a healthy mind would not contemplate taking their own life. That's not a healthy thought. And whether that spawns from depression or other issues or whatnot, that's something that needs to be addressed.
In 2014, the CDC reported that 1 in 6 high schoolers reported feeling suicidal. In the 2015, it's 1 in 5. That's 20% of our students are seriously contemplating suicide now. It's 20% of our future population.
Be a Lifesaver gives presentations in high schools all across South Dakota, so students will know how to react if one of their classmates is contemplating suicide. They engage audiences with Ian Carl's story by emphasizing that suicide is preventable. They stress that if someone hears another person is depressed or suicidal, he or she needs to tell someone who can help. They educate about the local and national resources that help with depression and suicide thoughts. Lastly, they provide youth with an innovative system to anonymously alert an authority figure if he or she hears someone is depressed or suicidal and they're reluctant to quote-unquote squeal. So if you want to learn more about Be a Lifesaver or want them to come to your community school, visit their website at be-a-lifesaver.org. Comments about the comments that Be a Lifesaver is advising?
I think the #1 preventative measure for suicide is to talk about it. And I think the more we can be open and have this discussion, the more that we can go into the schools and talk to the kids about the dangers that are out there with drugs and alcohol and all the bullying that's occurring and how this can affect mood and depression. And then what to do when a child is contemplating suicide. I think we'll see a lot of those rates start to decline. But we got to start talking about it.
We got to start talking about it.
Yeah, communication is the key, and every additional resource, and that was a very touching story,
Well done.
and I think to see those survivor stories, that the emotional response it evokes in us, and I'm sure when they share Carl's story, others. So the other thing I'd like to mention, she talked about the National Suicide Prevention Lifeline, another great resource. So 211 in this area, a very simple call. You can reach out, anonymous, confidential, and they've actually started a texting program for high school kids, and now a college program, of which Brookings, Augustana, and USF are in there. You can go to their website to get on to the to register for the texting program. But the Lifeline will also do education and postvention as well as intervention. So they have a survivors monthly meeting. They have a 9-week course for survivors. So it's a great resource, probably underutilized.
Just dial 211.
Right.
See, I didn't know that. That's an important number. Remember that, 211. We've got a caller from a 74-year-old man from Aberdeen talking about suicide and wants you to make note that the largest group committing suicide over the age of 60 is over the age of 60 years of age. He wants you to talk more about the elderly population that are committing suicide. I know that the state, the president of the AMA had made some comments about guns. He got into all sorts of hot water because there's a fair amount of people who think that we need to be able to have guns or freedom to have guns. And he came out of this realizing that the highest risk for suicide in our country per capita is the elderly male widower who just lost his wife. And that his suggestion is, if you know of somebody like that, connect with them, call them up, have pie with them. He needs a little company. He needs to have meaning.
Yeah, so you just touched on a very difficult group of people to help. And in this state, often they're living on a farm in rural South Dakota and don't even maybe have a neighbor in the immediate area. All alone.
Just lost their partner.
Right, and firearms are a part of our lifestyle, and like I say, wherever you stand on that, I get it. So, usually we have to invoke family, try to, because again, removing means, but hopefully being there, being the active listener, being aware of what you're going through, but that's really tough when you've lost. And the other thing is, when you start taking things away from people as you get older, that's a touchy subject, touchy at any age, but I can remember one of the hardest conversations I ever had was having to take my dad's right to drive away because he just wasn't cognizant anymore. That is touchy. Taking away guns, restricting means is very difficult.
Yeah, real tough. 85-year-old woman from Pierre, please explain bipolar depression. Shawn.
It's maybe a little bit better for Dr. Stanley, this question. Bipolar depression, I think, when you look at what bipolar disorder is, and we tend to see highs and lows, I guess you might, in moods. And people, when they have bipolar, I mean, a majority of the time, they do spend in those lows or in those depressive states. And it's also probably one of the biggest risk times that a person has is when they are depressed. You tend to see people, when they have bipolar depression, it might affect not only their mood, but their sleeping patterns. You might see people that get these elevations in mood for a while, and then all of a sudden they kind of drop off and get more depressed. But you do see the kind of this waxing and waning of their moods over time.
Yeah, I know that there are people who have normal swings in their mood. Sometimes you feel like you've got the world by the tail, and the other day you go, and the next day you feel like, wow, I mean, how bad life is. Multiply that times 100, and that's what they do, these swings.
Yeah.
When they're on high, they want to buy everything. They want to run for president.
Right, their mood is expansive, their energy is excessive, their confidence is over the top, and they don't need sleep, and they're not tired. So as Shawn said, so one of the diagnostic criteria is able to sleep or have essentially no sleep for 5 days in a row and continue to feel energized and ready to go. One of the problems with bipolar disorder is, so that's an intoxicating feeling. The problem with bipolar folks is even when we manage them, they spend about 60% of their time depressed, 30% in a neutral, and 10% manic. But it's that 10% manic that makes them non-compliant to meds, because they know if they stay on meds, I'll never feel that again.
Yeah.
So it's you know, it's a tough
deal.
It's often tough to treat.
And you know, there's a joke about running for president right here, but I'm not even going to go there. Via email, isn't a lot of drug use related to self-medication for mental illness?
That's a great question, and you know, I don't know, again, if there's a simple answer to that. So chicken or egg is a very difficult concept. I do think that we recognize it more and more, that some people turn to drugs to try to feel better, or, you know, normal, whatever your terminology is. The problem is the drug becomes a problem in itself. So I don't rule that out. It's one of the most difficult diagnostic decisions we have to make with a patient. In some cases it doesn't matter. We really have moved from what we used to call consecutive treatment, where we would treat what we thought was the primary illness and then get the secondary illness treated, to concurrent treatment. We try to treat both at once.
The depression and the pre-suicide or the manic-depressive illness and the substance abuse.
Correct.
Talk about alcohol use and marijuana and meth and all these substances, Shawn. We're seeing our kids do that early. Is there a risk? What's the problem?
I think it's a big risk. It's a huge problem. You know, when you look at a lot of the substances that are being used, especially alcohol, alcohol is a depressing or a depressant type of drug. So the problem becomes, you know, people start drinking to try to improve their mood, or try to at least get some sense of escape from reality for a period of time, but the effects that that drug is having on the body when they're using it continues to be there. And so you look at people when they're drinking, it starts affecting their sleep. That contributes to making their depression worse. You start looking at things like marijuana and how, you know, we like those highs, but there's always the lows that come when we get off the drugs, and we might be able to kind of escape reality for a while, but those things, those stressors that are still there, are going to be present when that drug is wore off. And a lot of these drugs, you know, when they just impair our ability to make good decisions, they're disinhibiting, so we're more likely to do things that maybe we wouldn't do if we weren't under the influence. Going back to the issue with guns, I mean, there's studies that have shown that if intoxicated, or if on some kind of a stimulating drug like meth or cocaine or what, we're more likely to use more lethal means and to try to hurt ourselves going to the gun. So I think we have to be very cautious just the impact these are playing.
60-year-old man from Sioux Falls, how much are mental, emotional problems just people living in their own little world?
Well, I think that's a good question. I think we're, for the most part, talking about biologically regulated mood disorders, but there are a lot of people that are dysphoric because they have become detached or disenfranchised from society. Probably the biggest protective factor we have in preventing suicide is connectivity. And you'll see that in almost any form of mental illness. Kind of the more supportive environment, the better the outcome. So I'm not sure if I'm totally interpreting that gentleman's question correctly.
But great answer.
But it is important that we are connected to the world as we know it. We're social animals.
We're going to be doing a show on blue zones, you know, longevity, coming up. And there's a book about blue zones, the areas that people live the longest, you know, and of course it has to do with eating enough grains and of course exercise and all that stuff. And connectivity, how important connectivity is. And I mean, if you look at our society where we can be connected, it's church, it's school, it's friends, you know, it's playing cards with people, it's going on trips with each other, it's interactive with your partner.
So you just inadvertently listed protective factors against suicide by just listing factors of connectivity. So here's an interesting question, though, that we don't necessarily know the answer. Does social media connectivity equate, does it equate to personal connectivity, which I don't have the answer.
You don't have the answer?
I don't know.
You're supposed to know. Do you know the answer to that?
I don't, but we've had some of our residents actually in our program looking at kind of that question. You know, does a person's connectivity through social media lead to less depressive feelings or more? And it'll be interesting to kind of see as they kind of get those results back exactly what that means. A lot of people, especially kids, their main source of social interaction today is Facebook or email, Twitter. And I've had a lot of kids that have told me that their best friend is someone they've never met before on the East or West Coast, but they're connected just through social media.
Yeah, my sense is it's going to be a good thing, but maybe not as good as looking at somebody eyeball to eyeball, you know what I mean? What are your thoughts? Oh, somebody was asking about penitentiary. 75-year-old woman from Lisbon. What mental health treatment is available to inmates in the state pen?
So we do know in the state pen there's a Jameson Annex that does, was specifically designed to treat patients with mental illness. One of the difficulties we also know about the penal system is that it's that mentally ill are far overrepresented within that population. Being an inmate is actually, or a suicide risk factor. So there is help available. There is a psychiatrist and there is psychiatric medicine practiced in the state penitentiary. What I don't know, because I don't practice there, is if there is enough available.
Yeah. And I'll ask you one more question. So if a person is taking their medicine for depression and they're exercising, do you both believe that it makes a difference? That the exercise is that important? Shawn?
I think when you put the whole picture together, I mean, I think we always teach residents it's a biopsychosocial model of treating a patient, and I think that's true for a lot of things: exercise, diet, medications, therapy.
Okay. And now for the answer for tonight's Prairie Doc quiz question. The risk of suicide for teenagers is 4 to 10 times higher if they live in a home where guns are present than in homes without. Matt, true or false?
True.
I would say true.
You agree? The answer is true. And the winner is Jean Bloom from Brookings, who correctly answered our question. Thank you, Jean, for your answer. The book will be in the mail. The check is in the mail soon. We'll be right back after this.
Suicide touches the lives of many Americans. You may know someone who's attempted suicide or someone who died from it. Perhaps even you have had thoughts of suicide. For every American who dies from suicide, many others attempt it, and even more may consider taking their own life. I need your help. Please call the number on your screen to learn how you can help prevent suicide.
In the medical profession, we often have to face suicide casualties. The victim and the family generally come to the emergency room, one by ambulance and the others to the waiting room. And there, one of us ends up talking with the family, people wrought with terrible anguish and guilt, even though the family may have done all they could to prevent it. In situations like these, I find myself overwhelmed with feelings of tragedy and sadness, and often angry at the suicide victim for causing such grief for the ones who really loved him or her. I have two examples. A successful and beloved Atlanta businessman who had been functioning with manic-depressive illness his whole adult life had overstretched his finances and challenged the relationship with his wife. Seeing the possibility that suicide might happen, the family was scrambling to prevent it, and yet during a depression dip that followed a short manic episode, he ended his life with a gun. An awful consequence of this act came years later when one of his children followed suit with his own suicide. I wonder if the dad's suicide could have been prevented had he realized that his example probably influenced his son's death. A young and handsome hospital emergency room worker had a failing marriage and left a message to his fellow hospital workers that the next time they would see him, they would be putting him into a body bag. This man with so much potential for good could easily have had another woman to love, but the body bag prediction still came true. We later learned that he had sent his divorcing wife a vindictive dozen roses with a hateful message, all to be delivered after his death. It left me feeling angry, not sad. In general, I knew him to be a fun and engaging sort who had a nice way with patients. I wonder if his suicide could have been prevented had he realized how destructive this act would be not only to his wife, but to his friends and fellow hospital workers. There have been too many examples of people who have ended their own lives due to financial problems, drug and alcohol addiction problems, health problems, love life problems, loss of something problems, and always mental health problems. Of course, mental illness can blind the victim of the consequences of that act, but if people realize the appalling path of destruction that follows suicide, maybe someone could be saved. Always there are better answers to that person's situation. Always there is help available from your doctor, minister, counselor, friend. And always there is terrible grief for the ones who remain alive. Well, this is Suicide Week, and there is flags on the campus, 1,100 college kids that die by suicide every year. Any messages that you want to make sure that we leave them regarding this week and this valuable, important message?
I think the biggest message that can get out there is we have to ask. You know, when we have concerns about a loved one, a friend, a family member, we have to get past the fear of asking the question about, are you having thoughts of wanting to hurt yourself or kill yourself? It's a tough thing to ask, but no studies have ever shown that asking that question actually leads to suicide. In fact, it gives the patient or the person an opportunity to actually share that they are having those feelings. If we don't ask, they're not going to tell. We have to be willing to ask the question.
We need to be quick to ask that question.
Yep.
Yeah, Matt.
And don't be afraid to act. I think, you know, better to potentially overreact and live with a lifetime of remorse. So these are tragic events. As I look at the 11,000 students, you know, whose parents sent them away full of hope and potential and never to see their child alive again, yeah, that just kind of sums it up for me. I hope that we can do a better job as physicians and as communities, but we just have to be able to talk about it and able to listen.
Very good. Well, I thank our studio guests, Shawn VanGerpen and Matt Stanley, for bringing their valuable insight into this discussion, this tough discussion of suicide. And thank you sincerely for joining us tonight as we glimpsed into dark corners where suicide lives. Psychologist Carl Menninger noted that hope is necessary for normal life. The best result of tonight's program would be that the light of hope might brighten up at least one of those corners. So from all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
More than just a smile, our teeth and gums have a significant effect on our overall health and well-being. Dental and oral health. Next time, On Call with the Prairie Doc.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization of South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care, Sanford Clinic, Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation.